Hello, and welcome to this presentation by the Foundation for the Education and Research in Neurological Emergencies. This educational lecture is titled Managing Emergency Department Headache Patients, Life-Threatening Headaches and COVID-19 Implications. Hello, today we're going to talk about the management of emergency department headache patients with the focus on life-threatening headache and COVID-19 implications. My name is Ed Sloan. I'm Professor Emeritus at the Department of Emergency Medicine at the University of Illinois at Chicago. I've been an attending physician at Carle Foundation Hospital in Champaign, Illinois, and I'm Medical Director of the Physician Assistant Studies Program of Dominican University in River Forest, Illinois. I've practiced emergency medicine for 35 years, and I hope my experience and this educational effort will improve your care of patients with acute headache emergencies. I'd like to thank Sam Ashu, who helped us with the EB Medicine podcast that was recently recorded, and I'd like to thank Erica Scott, Angie Wallace, and Stephanie Williford, all of the EB Medicine group. EB Medicine has done a great job in providing monographs monthly that cover emergency medicine topics for the past 26 years. I'm Fern President and Board Chair. I have no financial conflicts, and I do note that EB Medicine supported the development of this slide presentation. Our educational objectives. We want to provide the platform for increasing competence, which includes knowledge and strategies for using that knowledge and improving patient care. We want to improve performance in practice and ultimately improve patient outcomes. Specifically, we want to talk about secondary headache etiologies that are life-threatening. It's important to know how these ED patients present. We need to be able to diagnose and treat these patients effectively, and we'll consider headache and other COVID-19 factors. An overview. The content literature, this information provided comes from the monograph Evaluation and Management of Life-Threatening Headaches in the Emergency Department by David Zada, Gabriel Procopio, and Amit Gupta. It's part of the Emergency Medicine Practice Series. It was published by EB Medicine in February 2019. This is the Emergency Medicine Practice cover that includes the information and the editorial board. When considering patients with acute headache, we need to consider three involved structures: the CNS tissue itself, including the brain and spinal cord, the blood vessels, and the meninges. And then we need to consider that there are primary and secondary headaches. When considering headache etiology and diagnoses, it's sometimes first helpful to look at the Merriam-Webster definition of headache, which is simply a pain in the head. When you consider headache, 90% are primary etiologies that originate in the brain, such as cluster headache, migraine headache, or muscle tension headache. 10% occur with secondary causes, such as when a patient has a headache related to sinusitis, pharyngitis, vomiting, or dehydration. But there are also other secondary causes that include life-threatening secondary diagnoses. What are those secondary diagnoses that are life-threatening? They include subarachnoid hemorrhage, carotid and vertebral artery dissection or cervical artery dissection, central venous thrombosis, idiopathic intracranial hypertension, giant cell arteritis, posterior reversible encephalopathy, and meningitis and encephalitis. Additional secondary headache diagnoses include acute angle closure glaucoma, pregnancy-induced hypertension, carbon monoxide poisoning, and other head and neck infections, including sinusitis, pharyngitis, and lymphadenitis, which we'll address. The headache history. Our headache history should follow the OPQRSTU format. O, onset. Is it a sudden onset? P, provocative and palliative. Is it exertional in any way, such as with lifting weights or exertion? Q, quality. Is it sharp or overwhelming in some way, or is it a dull headache? R, radiation. Does it cause pain in the neck? Severity. Is it severe or is it the worst headache ever experienced? Temporal. Is it constant or changing? And U for under care. Is the patient under care by a clinician for these headaches, and are there specific headache medications or other medications that might be impacting this? Headache-associated items. Are there infection symptoms in the head and neck? Is there dehydration caused by nausea, vomiting, heat, or poor PO intake? Are there stroke symptoms? Are there cardiovascular symptoms such as near syncope or chest pain? Is there dizziness associated with the headache? Has there been some remote trauma? And is there a specific headache history? What are our headache historical red flags? The historical red flags really include, is it a sudden severe onset with severity that occurs within minutes of the onset of the headache, such as being hit by a baseball bat in the head? Is it new age onset greater than age 50? Is there significant neck pain? This is significant. Is there a malignancy history? Is the patient immunocompromised? Has there been an episode of syncope or trauma? And is the patient pregnant or postpartum? The headache physical exam. The general physical exam looks at vital signs. Is there fever, abnormal vital signs? Is the patient hypertensive? Is there apparent Cushing's response? Is the patient well appearing? Is there altered mental status, dehydration? Is there any evidence of pain or respiratory distress? Is there rash or any skin changes? Are there petechiae? Any evidence of dysrhythmias on the monitor or on cardiac exam? And is there any evidence of chest, GI, or GU infections? The head and neck physical exam is important in patients with headaches. Why? There can be sinus tenderness or temporal artery tenderness. There can be tympanic membrane or ear canal infection or abnormalities. There can be evidence of pharyngitis or retropharyngeal abscess, which can cause headache. There can be evidence of dental abscess. There can be nasal polyps or any green discharge, which would suggest infection. There can be neck swelling or tenderness or bruise. And most importantly, there can be evidence of meningismus, where there's specific pain in the neck with movement. The eye exam in a headache patient is also important. You want to know if the patient has adequate visual acuity. Can they count fingers at the bedside? Is there evidence of any vision loss or peripheral vision loss in one or both eyes? Is there a visual field abnormality? Is there a field cut, or is there an evidence of tunnel vision? Is there diplopia? And this diplopia can either be vertical, where one object is on top of the other, or horizontal, where the two objects appear to be side by side. Are the pupils equally round and reactive? Might there be a Marcus gun pupil? Are the extraocular muscles intact? We want to know specifically, are cranial nerves 3, 4, and 6 working adequately, or are there deficits? Lastly, the presence of a lid lag could suggest a cranial nerve 3 palsy. Then you want to look at the fundus of the eye to make sure that the discs appear sharp, that there's no evidence of papilledema and or hemorrhage or poor vascular supply. The headache neurological exam. You can use the AVPU system. Alert, responds to verbal, responds to painful, or unresponsive. And you want to just generally comment on their mental status. Speech. Is there receptive or expressive aphasia? Is there dysarthria, difficulty in being able to speak? What is the motor functioning of the face and extremities? Is it normal? Is there truncal ataxia, where a patient can't sit up straight in a cart without holding on? Is the Romberg positive? Is the gait normal? Every patient needs to be discharged after you've proven that they can adequately ambulate, if they were able to ambulate before the onset of this headache. You'd like to know about coordination, such as finger to nose or heel to shin testing, and check for any abnormal reflexes. And lastly, you want to do some brief neuropsychiatric assessment to make sure that there's not some overlying psychiatric problem influencing the occurrence of a headache. What are the headache physical exam red flags? The red flags include an altered level of consciousness, such as a poorly responsive patient, presence of a seizure, fever, meningismus, where the neck appears stiff or the patient can't move their neck without pain, the presence of visual acuity changes and/or cranial nerve abnormalities are clear red flags, as is a focal neurological deficit or acute psychosis. The occurrence of acute psychosis could suggest encephalitis, which may result in acute psychotic episode. Headache laboratory testing. Laboratory testing should include a glucose to make sure that alteration in mental status is not due to hypo or hyperglycemia. Surely a pregnancy test will help in the setting of presumed or suspected pregnancy-induced hypertension. You can get basic labs including a CMP, CBC, and UA, looking for abnormalities in liver functions, for example, or creatinine or dehydration on a urine sample. Also, you're looking for signs of infection. You can do an ESR and CRP, markers for inflammation, but please note that these have a limited sensitivity in the setting of giant cell arteritis. A venous carbon monoxide level will be helpful when you have multiple people who have a headache in one setting, such that CO poisoning might be suspected. And lastly, you might do a D-dimer. This will exclude a cerebral venous thrombus, but only in low-risk patients. This D-dimer is not helpful in patients who are thought to be high or moderate risk following your initial assessment. Lumbar puncture. The question often comes up whether or not a CT should be performed prior to lumbar puncture. I would generally recommend that this be the case, as it is possible as you draw off fluid that herniation can take place, and a non-contrast CT will give you any indication of increased intracranial pressure prior to performing the lumbar puncture. If you wish to obtain the opening pressure, you should have the patient in the left lateral position so that if they're not upright, it won't influence the occurrence of an elevated opening pressure. If you don't check the opening pressure with a manometer, you can always just assess it as if to say there are a few drops coming out slowly, which suggests no increased ICP. Or if the fluid's coming out rapidly, you might put the stylet back in and actually formally check opening pressure, because if the fluid's coming out rapidly, that would suggest possible increased intracranial pressure. When you do the LP, you want to obtain the smallest amount of fluid, less than a cc as possible per tube. And when doing the lumbar puncture, you can use 4 tubes. Tube 1, hematology for cell count and differential. Tube 2 for chemistry, looking at glucose and protein. Tube 3, microbiology, gram stain, culture, viral testing, and fungal testing. And Tube 4, a repeat hematology tube for cell count and differential. Now, what about headache neuroimaging? The most commonly used first neuroimage test is a non-contrast head CT in the emergency department. We understand that this test is relatively low yield, that in most all settings, the yield for a positive finding is less than 10%. However, the presence of a negative non-contrast CT has a high clinical utility. It's usually accurate and allows the patient to be dispositioned home once you know that there isn't some space-occupying lesion or other problem. So it is the initial test of choice in all AD patients that require neuroimaging in general, knowing that it's useful in excluding subarachnoid hemorrhage, other types of hemorrhage, abscess, space-occupying lesion, edema, mass effect, and/or midline shift. Now, in headache, there are other tests that you need to consider. You need to consider whether or not a CTA or CTP should be done for ischemic stroke, CTA for subarachnoid hemorrhage, which excludes aneurysm, MR venogram for CV thrombosis, an MRI for vasogenic edema in PRESS, which we'll talk about, and CTA and/or MRA of the head and neck if dissection is suspected. In our discussion of neuroimaging for patients with headache and suspected life-threatening emergencies, it's helpful to talk about the ACEP, American College of Emergency Physicians, clinical policies that address acute headache. The first one was published in October 2008. It addressed headache in adults with 5 questions. And there were 3 levels of recommendations based on the strength of the evidence. Most recommendations are level B or C. Level A recommendations, which are sure that everyone should follow, don't require a clinical policy most often to be developed. It's in those areas where there's some uncertainty that clinical policies are developed, and those generate, for the most part, level B and C recommendations. So regarding emergent neuroimaging in adult patients with headache, level B recommendations include any patient with new abnormal findings in a neurological exam, including a focal deficit, altered mental status, altered cognitive function, should undergo emergent non-contrast head CT. And emergent studies are those essential for a timely decision regarding potentially life-threatening or severely disabling entities or headaches. Secondly, any new sudden onset severe headache should undergo an emergent head CT. So sudden severe headache, which might suggest subarachnoid hemorrhage, requires emergent neuroimaging. And any HIV positive patient with a new type of headache that they've never had before should be considered for an emergent neuroimaging study. A level C recommendation from this same question states that patients who are older than 50 years of age and presenting with a new type of headache, but with a normal neurological exam, should be considered for an urgent neuroimaging study. And urgent studies are those that are arranged prior to discharge from the emergency department with the appointment as part of the disposition, or performed prior to disposition when follow-up can't be assured. In general, in the United States, because of the availability of CT scan from the emergency department, most times this level C recommendation will become a recommendation for emergent CT scanning. So the most recent update of the clinical policy that was published in October 2019 by Drs. Godwin, Cherkas, Panagos, Shi, Binney, and Wolf has some new updates regarding questions with patients who present with headache. So this ACEP clinical policy, published in October 2019, again followed adults, and it had 4 questions. Again, 3 levels of recommendation based on the strength of evidence, knowing that most are going to be B or C recommendations, but there are a few level A recommendations. The first ACEP clinical policy question has to do with subarachnoid hemorrhage risk stratification. And it asks, in the adult ED patient presenting with acute headache, are there risk stratification strategies that reliably identify the need for emergent neuroimaging? This question generated a level B recommendation that states the following. Clinicians should use the Ottawa subarachnoid hemorrhage rule as a decision rule that has high sensitivity to rule out subarachnoid hemorrhage because there are few false negatives, but it has a low specificity to rule in subarachnoid because the criteria generate many false positives. And using this for patients presenting to the ED with a normal neurological exam result and a peak headache severity within 1 hour of onset of pain symptoms, which suggests a sudden severe headache. What's in the Ottawa subarachnoid hemorrhage rule? The criteria that all need to be negative in order to rule out subarachnoid hemorrhage include age greater or equal to 40 years, complaint of neck pain or stiffness, witnessed loss of consciousness, onset with exertion, thunderclap headache, and limited neck flexion on examination. If all of these are negative, you can exclude subarachnoid hemorrhage. If any of them are positive, subarachnoid hemorrhage still must be considered. The other part of this level B recommendation regarding subarachnoid hemorrhage risk stratification states the following. Although the presence of neck pain and stiffness on physical exam in the ED in patients with an acute headache is strongly associated with subarachnoid, do not use this or any other single physical sign or symptom to rule out subarachnoid. In other words, it's important to use the aggregate Ottawa subarachnoid hemorrhage tool and not any specific part. Another question from this ACEP policy asks the question about primary headache treatment. In brief, it says, in the adult ED patient treated for acute primary headache etiologies such as cluster, migraine, or tension headaches, are non-opioids preferred over opioid medications? And this did generate a level A recommendation to preferentially use non-opioid medications in the treatment of acute primary headaches in ED patients. The ACEP clinical policy also asked about the utility of CT scanning, non-contrast CT, in subarachnoid hemorrhage within 6 hours. Here's the question. In the adult ED patient presenting with acute headache, does a normal non-contrast head CT scan performed within 6 hours of headache onset preclude the need for further diagnostic workup for subarachnoid hemorrhage? This is an important question for all emergency physicians and their patients. The level B recommendation that generated states the following. Use a normal non-contrast head CT, minimum third generation scanner, when performed within 6 hours of symptom onset in an ED headache patient with a normal neurological examination to rule out non-traumatic subarachnoid hemorrhage. In other words, a modern generation CT scan should be able to rule out subarachnoid hemorrhage in patients, even those with sudden severe headache, if performed within 6 hours of symptom onset. The last question from the ACEP clinical policy, published in 2019, addresses subarachnoid hemorrhage patients or those with suspected SAH and whether or not a CTA or LP is the preferred test to be performed following a non-contrast CT if there's still suspicion for SAH subarachnoid. Here's the question. In the adult ED patient who is still considered to be at risk for subarachnoid hemorrhage after a negative non-contrast head CT, is CTA of the head as effective as LP or lumbar puncture to safely rule out subarachnoid? This question generated a level C recommendation that states perform LP or CTA to safely rule out subarachnoid in the adult ED patient who is still considered to be at risk for subarachnoid hemorrhage after a negative non-contrast head CT. In other words, it doesn't have the strongest level of evidence support, but still there's a level C recommendation to be considered, saying that you can do either a lumbar puncture or a CT angiogram of the brain. One last issue regarding neuroimaging in patients with headache. I just wanted to point out that optic nerve sheath ultrasound has been considered as a modality for addressing patients with acute headache. So, ocular ultrasonography can be used in patients with headache and suspected increased intracranial pressure. So, the sonogram looks at optic nerve sheath diameter. The normal optic nerve sheath diameter is up to 5 millimeters, and when on ultrasound this optic nerve diameter is greater than 5 millimeters, it does predict an intracranial pressure greater than 20 millimeters of mercury, which would be an increased intracranial pressure. And what it does is it acts as a bedside CT to help assess the possible presence of elevated intracranial pressure. When considering secondary headaches that could be life threats, subarachnoid hemorrhage, of course, is the most important disease to be considered. Sudden, severe thunderclap headaches are what we're looking for. These are headaches with maximum severity in a matter of minutes from the time of headache onset, as if you were hit by a baseball bat, for example. Maximum severe intensity in minutes. Significant morbidity and mortality can result with subarachnoid hemorrhage, so having a high-quality ED diagnostic strategy is important. This includes making sure you know what the timing of the sudden ictus was, knowing that there are often precursor episodes of headache that portend the occurrence of this subarachnoid hemorrhage. We'll talk a little bit about the CT versus LP versus CTA strategy and the ACEP clinical policy. On this slide, you can see both the ring-shaped collection of blood that matches the distribution of the circle of Willis that's in the brain. Let's talk just a minute about likelihood ratios. If you have likelihood ratios between 0 and 1, this decreases the probability of a disease. So a negative likelihood ratio of 0.5 might decrease your likelihood of disease following a priori or pre-test assessment by 15%. A likelihood ratio of 0.2 decreases the post-test assessment by 30%, and a likelihood ratio of 0.1 decreases it by 45%. This is a large decrease. So a positive likelihood ratio is just the opposite. A positive likelihood ratio of 2 only increases the likelihood of disease by 15%, a likelihood ratio of 5 by 30%, and a positive likelihood ratio of 10 increases your likelihood of disease by 45%. So let's give an example. Let's say you see a patient with headache, sudden severe. You think there's a pretest probability of subarachnoid of 10%. If a positive likelihood ratio of a symptom or sign is 6.6, that means the post-test probability increases by 35%. And so your post-test probability will increase 40 to 45%. So the pretest odds of subarachnoid were 1 in 10, and the post-test odds of subarachnoid hemorrhage is now almost 1 in 2. So what findings suggest subarachnoid hemorrhage? The finding of meningismus has a positive likelihood ratio of 6.6, and the complaint of neck stiffness a positive likelihood ratio of 4.1. Focal deficit has a positive likelihood ratio of 3.2, and others are listed on this slide. But if you look at the most important ones, meningismus, neck stiffness, focal deficit, photophobia, or loss of consciousness, this has a 15 to 35% increased risk from your pretest probability of subarachnoid hemorrhage. Now, the Ottawa subarachnoid hemorrhage rule has inclusion criteria for patients 15 years of age or older, normal Glasgow Coma Scale score, new onset severe headache, and maximum intensity within an hour. There are many exclusion criteria that are listed here, and these exclusion criteria are the ones that will be critical to our ability to rule out subarachnoid hemorrhage. If you look at the exclusion criteria, and all of them are negative, it actually has 100% sensitivity, no false negatives, for excluding subarachnoid hemorrhage. So you could develop these into a dot phrase where you say, the patient I have is age less than 40, has a negative history, no loss of consciousness. It is not an exertional onset headache. It is not a thunderclap headache, not sudden and severe. There's no neurodeficit, no papilledema, no neck pain, tenderness or stiffness, and no meningismus. If you can put this into your note, you can say, and quote, the risk of a subarachnoid hemorrhage approaches 0 such that testing beyond non-contrast head CT is not clinically indicated. I've discussed it with the patient is aware and agrees with the plan. Now, the ACEP clinical policy from 2008 addressed testing for patients with headache. And at that time, they said if the CT is negative, is a lumbar puncture indicated? And it generated a level B recommendation that says the following: in patients presenting to the ED with sudden onset severe headache and a negative non-contrast head CT scan result, lumbar puncture should be performed to rule out subarachnoid hemorrhage. And note that this statement does not apply to any other ED headache patients, only those with sudden severe headache, which are nearly all of our patients. So, is an LP indicated if the CT is negative? We know that most of the recent literature suggests that a CT-only approach without LP is appropriate when headache ictus is less than 6 hours prior to exam. The CT ability to detect subarachnoid hemorrhage continues to improve, such that post-test probability of the subarachnoid after a negative non-contrast CT is significantly lower. It has a very clinically useful negative likelihood ratio, and if that negative likelihood ratio approaches 0.1, that means there's nearly a 50% risk reduction for subarachnoid hemorrhage. Now, what about more testing if the CT and LP are negative? The 2008 policy generated a level B recommendation regarding subarachnoid hemorrhage diagnosis, saying that patients with sudden severe headache, sudden onset, who have a negative findings on a head CT, a normal opening pressure on LP, and negative findings in CSF do not need emergency angiography and can be discharged from the ED with follow-up recommended. And it notes that normal ICP can be assessed clinically just by knowing that the fluid on lumbar puncture is not coming out rapidly. Now, what about CT angiography? Well, we know that LP is not useful when the exam is performed in LP within 6 hours after the ictus, and we know that the CT is useful when the exam is performed in less than 6 hours after the ictus. So we know in that acute setting, less than 6 hours, LP most often is of less value to rule out subarachnoid. And the question is, can CTA be performed following a normal CT? What's the logic? If you do a CTA and there's no aneurysm, then there's not a subarachnoid hemorrhage from a leaking aneurysm. Why CTA? Because CTA is a good exam down to 6 branches from the main cerebral vessels. So, for subarachnoid hemorrhage, CTA is clinically more useful and can be quickly performed from the ED than an MRA. Now, regarding subarachnoid hemorrhage treatment, blood pressure management, you want to achieve a systolic blood pressure of 160 millimeters of mercury or less. You want to use nimodipine, a calcium channel blocker, 60 milligrams PO, Q4 hours. There's only limited data on anti-epileptic drug therapy, but in general, it's probably not indicated unless the patient does have a seizure. And then there's ultimate aneurysm management, either by a clip or coil. So we addressed some questions. The most important one is, what about LP and CTA, and what about the performance of CT in patients with subarachnoid hemorrhage? Well, fortunately, the 2019 ACEP Clinical Policy, Critical Issues in the Evaluation and Management of Adult Patients Presenting to the Emergency Department with Acute Headache, was put together by Drs. Godwin, Cherkas, Panagos, Shi, Birney, and Wolf. And so this policy addressed adults with headache and asked 4 questions, giving 3 levels of recommendation based on the strength of evidence. Most are levels B and C, given that we only put together clinical policies when there's some uncertainty. But on occasion, there are a few level A recommendations that have certainty and uniform acceptance by clinicians. So one question was asked in this clinical policy by ACEP: in the adult ED patient presenting with acute headache, are there risk stratification strategies that reliably identify the need for emergent neuroimaging? And in fact, this question generated a level B recommendation that says use of the Ottawa subarachnoid hemorrhage rule as a decision rule that has high sensitivity to rule out subarachnoid, but low specificity to rule in subarachnoid for patients presenting to the ED with a normal neurological exam and peak headache severity within 1 hour of onset of pain symptoms. In other words, the Ottawa subarachnoid hemorrhage rule is a good test to rule out because it's highly sensitive with few false negatives. We understand that there are many false positives and it has low specificity, but the ability to rule out is dependent upon a good test with high sensitivity. and the Ottawa Subarachnoid Hemorrhage rule is such a test. It does note also in this level B recommendation that although the presence of neck pain and stiffness on physical exam in ED patients with an acute headache is strongly associated with subarachnoid, do not use any single physical exam sign or symptom to rule out subarachnoid. In other words, use the Ottawa Subarachnoid Hemorrhage rule in aggregate to exclude or rule out subarachnoid, and don't use any specific sign or symptoms to achieve the same objective. It also, this clinical policy from 2019, ACEP addressed the 6-hour CT utility to exclude subarachnoid with the following question. In the adult ED patient presenting with acute headache, does a normal non-contrast head CT scan performed within 6 hours of headache onset preclude the need for further diagnostic workup for subarachnoid? A level B recommendation was again generated. Use a normal non-contrast head CT, minimum third generation scanner to perform within 6 hours of symptom onset in an ED headache patient with a normal exam to rule out non-traumatic subarachnoid hemorrhage. In other words, if a good scanner, recent generation, is performed head CT within 6 hours, no need for lumbar puncture following CT scanning that is negative. Now, what about the issue of CTA versus lumbar puncture? In the adult ED patient who is still considered to be at risk for subarachnoid after a negative non-contrast head CT, is CTA of the head as effective as LP to safely rule out subarachnoid? ACEP has done a great service to us because they answered the two questions that remained following the 2008 clinical policy, and given the new advancements made in diagnostics, especially neuroimaging with non-contrast CT, and the availability of CT angiography. This question generated a level C recommendation, one that we should all consider, and it says, perform an LP or CTA to safely rule out subarachnoid hemorrhage in the adult ED patient who is still considered to be at risk for subarachnoid hemorrhage after a negative non-contrast head CT result. Another important secondary headache cause is carotid or vertebral artery dissection or cervical artery dissection. In carotid artery dissection, there might be neck pain related to some flexion or extension injury, and this injury could be remote and it could be mild. A patient states that they were cleaning out their closet and a box fell and hit them on the head, and then several days they have symptoms. It can cause anterior stroke syndrome or symptoms due to the carotid artery problem. It can cause hemiplegia, slurred speech, or Horner syndrome symptoms. In this picture, we have a demonstration graphically and on imaging of an internal carotid dissection defect seen in a drawing and on MR angiography. Now, what about this issue of Horner syndrome? A 59-year-old female presents with headache and neck pain for 1 day after cleaning her closets the day before. Her neck is diffusely tender and she has a left eye ptosis and miosis seen here. Again, this can be related to the carotid artery dissection. And you need to know that when a patient has a third nerve palsy, they can have ptosis and miosis as a result of third nerve dysfunction. What about vertebral artery dissection? Again, a patient may present with neck pain due to some mild or remote flexion extension injury. It doesn't have to be severe, but it can be. And in this case, there can be posterior circulation stroke symptoms. These would include dim vision, dizziness, diplopia, dysarthria, discoordination, or hemisensory complaints, more often pain and temperature, noting that we most often just check sensory light touch. What is the treatment for cervical artery dissection? The treatment includes medical treatment to prevent stroke, regardless if it's spontaneous or traumatic in etiology. Antiplatelet therapy has been shown to be as effective as antithrombotic therapy from the CADISP, CADISP trial. If there's an extracranial outside the cranium dissection, IV heparin, then oral anticoagulant is advised. If it is an intracranial dissection, it is advised that the patient be started on aspirin or clopidogrel. And if the patient can't be anticoagulated, use the aspirin or clopidogrel approach. And remember that it is most often not useful to have both aspirin and clopidogrel to be used for neurological diseases or problems, that the aspirin and clopidogrel approach, or aspirin Plavix, is most often useful in cardiac disease states such that there won't be a complicating hemorrhage or bleed as a result. The next important secondary headache syndrome is cerebral venous thrombosis. In whom might this occur? It might occur in pregnant patients, those who are postpartum, or those who have a hypercoagulable state. It might show with increased ICP signs. It may produce papilledema and a cranial sixth nerve palsy. It can present with neurological findings, stroke symptoms with hemiparesis, or posterior circulation symptoms, including dizziness. It may cause ataxia and/or seizures. This is a T2 MR image that shows a venous cerebellar infarct in A and an MR angiogram in B that demonstrates a cerebral venous thrombosis in the transverse sinus. In image C, this is a 3-month infarct T2 image that shows resolution of the stroke despite a persistent partial obstruction in the transverse sinus in image D. How do we treat patients with cerebral venous sinus thrombosis? If there's any infection suspected, antibiotics should be used if an infectious etiology is suspected or found, including sinusitis or cavernous sinus thrombosis. Anticoagulation therapy is recommended in patients with cerebral venous sinus thrombosis. However, up to a third of patients with a CVT will have some type of hemorrhage at the time of presentation, such that MR imaging should be performed to help exclude small areas of hemorrhage when diagnosing a cerebral venous thrombus. And in general, low molecular weight heparin can be given, then oral anticoagulation. The next important secondary headache cause that could be a life threat is idiopathic intracranial hypertension. This can occur in women of childbearing age, especially if there's been a sudden discontinuation in steroid use. A common story is that a young female has been on steroids, they stop them because of the side effects, and then they develop headache as a result. With IIH, you can have symptoms that change with change in position of the head. The patients may complain of pulsatile tinnitus. Patients may have a cranial sixth nerve palsy. And they may have horizontal binocular diplopia. That is, double vision induced with some type of lateral gaze where the images are next to each other on the horizontal plane. And IIH utilizes the modified Dandy criteria for the diagnosis. What's the treatment of idiopathic intracranial hypertension? With lumbar puncture, fluid can be withdrawn. This is a temporizing measure if there's severe headache, but in general, the patients are advised to have weight loss, low sodium diet, acetazolamide 250 to 500 milligrams PO BID, which decreases CSF production. This can cause or allow for a modest improved visual field functioning. Alternate therapies include topiramate 25 milligrams POQ day, furosemide 20 milligrams POQ day, and at times surgical options are necessary if the patient has IIH that is refractory to medical therapy. Another important secondary cause of headache to be diagnosed in the emergency department is giant cell arteritis. This is normally in an older patient who may present with temporal artery tenderness, especially if beating is noted on palpation of the temporal artery. These patients can complain of jaw claudication, that is aching in the jaw with use and chewing. They may have diplopia, vision loss. And when you are excluding or considering giant cell arteritis, especially when there's any evidence of vision loss, you must include the diagnosis of central retinal artery occlusion, CRAO, in your differential of acute vision loss when suspecting giant cell arteritis. What is the treatment for giant cell arteritis? In general, it's high-dose methylprednisolone, 15 milligrams per kilo per day, IV for up to 3 days, and then oral prednisone, 40 milligrams per day to follow for several weeks. A biopsy is generally indicated for patients with suspected giant cell arteritis, even if their ESR and CRP are normal, which can occur. The next important secondary headache cause to be considered in the emergency department is posterior reversible encephalopathy syndrome, or PRES. PRES can occur and present with an acute onset headache. The patient is noted to have significant hypertension. And really what happens and what is the cause of this headache is the loss of autoregulation of the CNS vessels. Normally, across a wide range of blood pressures, the CNS vessels have a maintained blood pressure in those vessels. But with loss of autoregulation, you can have problems related to encephalopathy, altered level of consciousness, visual changes, and seizures as blood pressure in the CNS vessels increases. How do we lower blood pressure? What is the treatment for PRES? You want to lower blood pressure to a safe range. And what is safe? I would say consider the 185 over 110 blood pressure used for safe administration of TPA as a reasonable number. You should always attempt to treat blood pressure by addressing mean arterial pressure, and you want to lower mean arterial pressure by up to 25%. This is an important point at which we can talk about mean arterial pressure calculation and treatment. Remember that mean arterial pressure is 1/3 your systolic pressure and 2/3 your diastolic pressure, as we spend 2/3 of our time in diastole. So a patient with a blood pressure of 120 over 90 has a mean arterial pressure of 40 systolic plus 60 diastolic equals 100 millimeters of mercury. A person with a severe high blood pressure of 210 over 135, their mean is 70 from systolic, 90 from diastolic, or 160 millimeters of mercury, quite high. What about that 185 or 110 blood pressure I talked about before that we utilize for safe administration of TPA? That 185 over 110 generates a mean of 62 systolic, 74 diastolic, or a mean of 136 millimeters of mercury. So in other words, a safe mean arterial pressure might be around 130 millimeters of mercury. So let's consider reducing mean arterial pressure by up to 25%. If the mean in a highly hypertensive patient is 160 and you reduce it by 25% or 40 millimeters of mercury, that reduces your mean arterial to 120 millimeters of mercury. And we already said that 130 millimeters of mercury is a reasonable point at which you can reduce blood pressure in that 185 over 110 range. So suffice it to say, a reduction of mean arterial pressure of 15 to 20% may be adequate even in patients with elevated blood pressure and the PRES syndrome. So as we stated, you can often safely only reduce your mean arterial pressure to a value of approximately 130 millimeters of mercury, similar to about a blood pressure of 180 over 105, with no need to further reduce blood pressure because you've reached a safe mean arterial pressure, especially if the patient's symptoms are improving. So what IV antihypertensives can be used? Nitroglycerin, a venodilator, can be used especially when there's suspected concomitant cardiac ischemia. You can give nitroglycerin at 100 to 200 micrograms per minute, monitoring blood pressure during this treatment. Esmolol, a cardiac beta blocker, can also be utilized when the patient is tachycardic. This can be given at 50 to 200 mics per kilo per minute. And lastly, labetalol, a combination alpha-1 and beta blocker, can be used in tachycardic patients. It can be given by bolus 20 to 40 milligrams every 10 minutes, up to a total of 300 milligrams. There are two other IV antihypertensives that should be mentioned. These are optimized with continuous infusion, especially in patients who are hypertensive and encephalopathic, such as with the Press syndrome, and they are often used in the neurointensive care unit. The first is nicardipine, one of the two calcium channel blockers we're addressing. Nicardipine can give it at 5 to 15 milligrams per hour, starting at a 2 to 5 milligrams per hour range. The other is clevidipine, a calcium channel blocker, 1 to 2 milligrams per hour range, maxing out at 16 milligrams per hour. The next important secondary headache diagnosis under consideration for ED patients with headache is meningitis and encephalitis. Remember that meningitis can be both bacterial and viral. For example, the patients with a viral meningitis may just have significant photophobia and phonophobia and just want to be in a dark, quiet room till it resolves. If meningitis or encephalitis is suspected, remember, you must provide ceftriaxone prior to having the patient go for non-contrast CT imaging. Steroid use should only be used once meningitis is confirmed by having a cloudy CSF suggesting a positive LP and bacterial meningitis. Whereas ceftriaxone should be given in all patients even when there's a low likelihood but there is a suspicion of meningitis, steroid use is really to be given only in those settings in which we know that there's a confirmed or likely bacterial meningitis in order to prevent complications. What are the etiologies? Strep pneumonia, group B strep, M, N, meningitis, H influenza, and Listeria monocytogenes. Those are a lot to say. We also have to consider non-polio enteroviruses, including group B Coxsackie and echovirus. And remember that patients with encephalitis can have altered mental status. They can be normal one day and with viral encephalitis have acute psychosis. What's the treatment for meningitis and encephalitis? In neonates up to 28 days, ampicillin with either cefotaxime or gentamicin and acyclovir if viral meningitis is suspected. In infants, give ampicillin and ceftriaxone. In adults 18 to 49, ceftriaxone and vancomycin. In adults 50 plus, ceftriaxone, vancomycin, and ampicillin, treating Listeria with the ampicillin. If there's a foreign body or the patient is post-procedure, give vancomycin and either cefepime, ceftazidime, or meropenem. And if there's a penicillin allergy, the drugs of choice may include moxifloxacin or vancomycin. But please note, if the penicillin allergy was just a rash as a child, it's probably okay to give the higher generation cephalosporins since there's a low cross-reactivity and allergy from the administration of these drugs. And these higher generation cephalosporins are great for CNS penetration and the treatment of suspected meningitis or encephalitis. The next diagnosis to be considered for patients with secondary headache in the emergency department is acute angle closure glaucoma. This disease is more commonly seen in older patients who may have a sudden exposure to bright light, such as leaving a movie theater during the day and going into the sunny outside. It will present with unilateral blurry vision, halos with vision, and vision loss. It can often have unilateral headache, especially headaches behind the eye. The eye itself will be painful and have some redness. And in general, acute angle closure glaucoma includes elevated intraocular pressures greater than 30 millimeters of mercury, knowing that normal intraocular pressure is somewhere in the range of 10 to 20 millimeters of mercury. How does this happen? Normally, the aqueous humor fluid flows from the posterior chamber to the anterior chamber, then into our bloodstream. And this fluid must pass between the iris and the lens, then through the pupil opening. and the fluid can get blocked, known as pupil block. And in acute angle closure glaucoma, the iris is so close to the trabecular network that when pupil block increases, it pushes the iris against the meshwork, blocking outflow of this aqueous humor. How do we treat these patients? Treatment is most often medical. You can use timolol beta blocker, 0.5% Q1 hour times 2. Pilocarpine, a miotic, 1 to 2%, 3 times over 30 minutes. Aproclonidine, an alpha-2 agonist, 0.5%, Q1 hours times 2. And refer immediately to ophthalmology. Many times they can be lasered in the office as needed to provide an opening and drainage for this aqueous humor. The next important secondary cause of headache in emergency departments patients to be considered is pregnancy-induced hypertension. This is hypertension with associated symptoms and/or lab findings. In general, you have to have a systolic blood pressure greater than 140 or diastolic greater than 90 millimeters mercury times 2 at least 4 hours apart, or any single reading of systolic blood pressure greater than 160 or diastolic greater than 110 times 1. Now, in addition, you must have proteinuria, thrombocytopenia, liver impairment, renal insufficiency, pulmonary edema, or new onset headache. The presence of the latter symptoms and not proteinuria renders the disease more severe. That is to say, you can have mild pregnancy-induced hypertension or eclampsia with proteinuria, but it's considered to be more significant if you have any of the other symptoms, including problems with the blood, liver, kidney, lungs, or neurosystem, including headache. What is our treatment for pregnancy-induced hypertension? Labetalol can be given 10 to 20 milligrams IV and/or hydralazine 5 to 10 milligrams IV by bolus. Nifedipine 10 to 20 milligrams PO can be provided. For severe pregnancy-induced hypertension, magnesium sulfate 4 to 6 grams bolus over 30 minutes, or magnesium 1 to 2 grams per hour till there are muscle or reflex changes, and what will occur, there will be muscle weakness and/or loss of reflexes. Another important consideration, a secondary headache cause, is carbon monoxide poisoning. These patients will have headache, nausea, vomiting, and perhaps peripheral cyanosis. The common story is that 5 different people in the same building or house or apartment have headache. You should always assume that it could be related to some problem with the heating element and carbon monoxide poisoning. Patients can get visual changes, altered mental status, coma, and/or seizures. It can cause cardiac ischemia or cardiac arrest. Now, we note that venous CO levels can be 3 to 8% carboxyhemoglobin in smokers, and that lethal levels are in the range of 40 to 60%. Now, we used to say patients with carboxyhemoglobin levels greater than 25%, for example, would require transfer to a center that has a chamber that will allow hyperbaric oxygen therapy. And the question is, who needs to be transferred for hyperbaric oxygen therapy? Now, we know with a high level, it's probably worthwhile if you have HBOT in your own institution to go ahead and provide this hyperbaric oxygen therapy if it's going to be safe. But the question is, when do patients need to be transferred? Well, clearly patients who have a high level greater than the 24 or 25 range need to be transferred if there's signs of acute myocardial infarction, cardiac arrest or ischemia, coma, and/or seizures related to significant CNS toxicity. Now, we know that the reason we do the hyperbaric oxygen therapy is to prevent some neuropsychiatric problem down the road, and it's difficult to predict how or when or why that might occur with or without hyperbaric oxygen therapy. But suffice it to say, patients with lower levels, perhaps less than 20% carboxyhemoglobin, who have no symptoms except for headache, can probably be treated with high flow 100% O2 in the emergency department. And once their headache symptoms resolve, you could recheck a CO level as needed, but otherwise, knowing their first venous CO level might be sufficient. The one question that has come up is, what about pregnant patients? We know that the fetal hemoglobin has a greater affinity for carbon monoxide, and the question is, do pregnant females need to be transferred? I'm not aware of data that suggests any specific cutoff that needs to be addressed with regard to hyperbaric oxygen therapy in pregnant patients, except to say the higher the level of venous CO, carboxyhemoglobin, that is detected, the more you might consider the hyperbaric oxygen therapy in pregnant patients. The last secondary headache cause in the emergency department to be considered is head and neck infections. We know patients can present with headache as a result of sinusitis, periorbital cellulitis, pharyngitis, retropharyngeal abscess, and or lymphadenitis. We know that with there's pain change in the position of the head, it could represent sinusitis. We know that when you do a head CT, it is important that the radiologist state clearly that there is not pansinusitis, or you must exclude it by noting adequate error in the sinuses on your own review of the CT. You need to distinguish periorbital versus orbital cellulitis, the latter being more significant. We know that these common infections can cause headache, and we just need to make sure that they're not present in all patients in the ED with headache. And remember, when in doubt, whenever there is a head and neck infection and you're obtaining a CT in a patient with headache, please administer ceftriaxone 1 or 2 grams IV prior to the patient going for their non-contrast head CT. The last section that we will review when considering patients with secondary headache in the emergency department and potential life threats is how we evaluate ED patients with headache in the setting of the COVID-19 pandemic. The question is, does COVID cause different types of headache or symptoms? Yes. And does it cause us to need to change the way in which we treat the most important head and neck infections and or headaches? And the answer to that is likely no. So let's talk a little bit about the COVID-19 CNS mechanisms. COVID-19 virus addresses or attacks the ACE2 receptors for access to our tissues. These ACE2 receptors are found in neurological tissues and actually in GI tissues where there's a lot of neurons. Brain access through the nasal olfactory epithelium and through the CNS capillary endothelial lining is the way in which COVID gets into our brain. This has the potential for causing cerebral edema prior to any diffuse organ system loss of homeostasis. The second article we review when considering COVID-19 and headache addresses CNS mechanisms. We know there can be direct infection via blood neurons. These infections can cause hypoxic injury through ACE2 receptor access, and they can cause immune injury through SIRS and the accelerated autoimmune response. This can cause infectious toxic encephalopathy, viral encephalitis, or acute cerebrovascular disease. Another article that addresses CNS mechanisms. We know that viral infections can cause a myriad of problems, and COVID-19 can cause seizures, status epilepticus, encephalitis, neuromyopathy, Guillain-Barré, transverse myelitis, or flaccid myelitis. We know with coronavirus, influenza virus, RSV, HMPV, and enterovirus, all of these can occur. And we note that there's a direct neurotropism of these viruses or an attraction of these viruses to neurological tissues and neurons. And so there's an affinity for these viruses to selectively localize themselves in the nerve tissue. What are the complications of COVID-19 when there's a CNS infection? Myalgias and headaches are common. There can be direct viral invasion of all of our neurological tissues. This can cause myopathy, polyneuropathy, and rhabdomyolysis. It can cause meningitis and encephalitis. The unique thing that COVID seems to cause is anosmia and ageusia, which is loss of smell and loss of taste. There can be a post-viral autoimmune process that complicates our nerves, and again, it can cause encephalomyelitis and/or Guillain-Barré syndrome. One COVID-19 case report included a 64-year-old Chinese patient with no medical history, a fever to 38.5 centigrade, cough, myalgias, and the patient became lethargic and unresponsive 13 days later after the initial infection. The patient was noted to have dissociated speech, ankylosing, Babinski, and Chaddock signs, and meningismus. Remarkably, the CT and LP were negative, and the patient recovered and was discharged from the hospital 17 days later. So again, we talk about what are the symptoms with COVID-19 besides headache. We know that symptoms neurologically can occur, especially in patients with severe illness, and these neurocomplications in about a third of patients fall into three categories: CNS, dizziness, headache, altered mental status, CVA or ataxia and or seizure, peripheral problems with taste and smell, vision or nerve pain, and skeletal muscle injury or neuromuscular problems. Now, what about COVID-19 and headache? One review article reviewed the experience of 41,000 patients. Headaches were noted in 8 to 12% of patients, and these were found in two disease phases. The first was the headache in the viral infection phase, and the second was a headache with hypoxia and with the noted cytokine storm that can occur. More about COVID-19 and headache. It's noted in up to 1/3 of hospitalized COVID-19 patients. These headaches can be variable in their presentation: new, sudden, or gradual onset, moderate, severe, throbbing or pressure, and we note that these patients can actually have poor analgesic response with COVID-19 related headaches. The headaches can be found to be bilateral, temporal parietal, frontal, or periorbital. We know also, similar to the poor analgesic response, that there can be a high relapse rate in the active infection phase, that is, recurrent headaches. We also know that there can be possible peripheral trigeminal nerve problems due to pro-inflammatory hypoxia and/or cytokines. COVID-19 can be associated with meningoencephalitis. Two case reports: a 64-year-old woman with no psych history was admitted to the psych ward, then had tonic-clonic seizures, some focal status. The MRI was normal. The LP did show or was consistent with meningoencephalitis. The patient was treated with acyclovir and remarkably improved over 4 days. Another 67-year-old woman, COVID was positive for 17 days, and then she had an intense wake-up headache, was confused, had syncope in the bathroom, which is always problematic due to hitting those hard surfaces. She had left-sided stroke symptoms. Her MRI was okay. She had CSF pleocytosis or cellular elements. She was treated with acyclovir and antibiotics and discharged after 4 days. Another remarkable case where a patient was critically ill and was able to be discharged home. Another report of COVID-19 and meningitis: a 24-year-old, 9 days into having fever, headache, and fatigue, was found to be unresponsive with emesis, lying on the floor. The patient had transient generalized tonic-clonic seizures. COVID-19 was detected in the CSF, and the MRI was positive in the lateral ventricle, temporal lobe, hippocampus, noting suggested meningitis. We know that COVID-19 can also be seen in the setting of orbital cellulitis. Two cases: one, a 12-year-old Egyptian male with 3 days of orbital swelling that had orbital cellulitis. Another, a 15-year-old male with 3 days of orbital swelling, was given ceftriaxone, vancomycin. The CT showed ipsilateral or same-side pansinusitis, orbital cellulitis, and epidural abscess. In the first case, the 12-year-old, the patient had surgical intervention, antibiotics, and improvement. The second case, this patient had surgery, a persistent fever, and a complicated course. We know that COVID-19 can cause thrombosis, as can any acute respiratory illness. This is a case of CNS venous thrombosis, a 59-year-old, 4 days with frontotemporal headache, diabetic, hypertensive, had a persistent severe headache and a fever. It actually showed, the CT showed superior sagittal transverse sigmoid sinus and IJ vein density suggesting of thrombus and a central venous thrombosis. It was thought originally to be negative. The patient then had more stroke symptoms with unilateral weakness, slurred speech, and expressive aphasia. The CTV venous venogram was reread and was thought to show sigmoid and transverse sinus defects. The patient was treated with low molecular weight heparin. The NIH stroke scale went from 10 to 4 at 24 hours, believe it or not, and was discharged home. Now, we talked about venous thrombosis. We also know that arterial thrombosis can occur with COVID-19. There's a case of a 64-year-old male, a wake-up stroke, left hemiparesis, shortness of breath. Patient did not receive TPA. It was noted that the patient 16 days prior to this event had a fever, myalgias, and was noted to have COVID-19. Patient was tachycardic, hypertensive, hypoxic, with respiratory failure, was intubated. The CT showed hypoattenuation and loss of gray-white differentiation. The CTA showed a high-grade ICA stenosis, but no IC occlusion. And the repeat CT at 24 hours showed cerebral edema, mass effect, and the right MCA and ACA territory. So a complicated case of thrombosis related to COVID-19. So, in summary, what do we know about ED headache patients and COVID-19? In the emergency department, headache patient life threats can still be identified in the presence of COVID-19 co-infection. We know that the systemic evaluation of these patients is critical, and the EMR can help us with dot phrases or templates to be utilized. We know that we can exclude subarachnoid hemorrhage effectively both with the Ottawa exclusion rule and with CT, new generation, and with the use of CTA as needed. We must always consider infection and thrombosis in all patients, including those with COVID-19 co-infection. We know that COVID-19 makes common headaches more commonly occur. We know that any time in this pandemic era that if you have a patient with a significant headache secondary etiology and you're considering the life threats, you should check to make sure that there is not concomitant COVID-19 infection. But in general, there's no need to alter our diagnostic and treatment protocols just because of the COVID-19 pandemic. In other words, treat these patients as you would have even without concomitant COVID-19 infection. So that ends our discussion of life-threatening headaches and secondary causes of headache that must be addressed by the emergency physician. We've been able to address many of the important causes of secondary headache, including how they might present, their diagnostic regimen, and their treatment regimens. We also discussed COVID-19 and its implication for the evaluation of headache patients in the ED who might have life threats as the cause of their headache. And we understand that it is possible to effectively diagnose and treat these patients even in the era of a COVID-19 pandemic. I encourage you to go to other sections of this headache lecture, either on the YouTube Academy site or on the fern.org site. We'll also have some links on the EB Medicine, evidence-based medicine site for your use as needed. There are also some CME opportunities available through the EB Medicine site. Once again, thank you for your attention and your participation in this educational process. If you have any specific questions related to this educational content, please send an email to fern.org@gmail.com. We encourage you also to go to the fern.org website for more content related to this educational program, as well as other content related to the care of patients who present to the emergency department with life-threatening illness and injury related to neurological emergencies. Please note the disclaimer listed below. In general, this information is intended to augment and not replace the clinical judgment that guides the management of any individual patient. Thank you.